Hello everyone and welcome back to Dr. Happy Vagina. This is an educational YouTube channel where we speak about different topics regarding women's health. And in today's episode we will speak about episiotomy. I will go through what is an episiotomy, how to perform it, and what could be the indications to perform an episiotomy during vaginal delivery. And we will go through a newly published amazing big study about episiotomy in women who are delivered with vacuum. So hang on to this very informative episode. So episiotomy, what does it mean? It means that we, as healthcare professionals, we perform a cut in the vaginal orifice when the woman gives birth to a baby. And why would we do that? Okay, so in this picture you see a woman in lithotomy position giving birth to a baby. Here is the baby's head coming out of the vaginal orifice. And you see around the head we will have the perineal body muscles. We have the bulbocavernosus muscle here, and we have the transverse perineal muscle here, and here we have the anal sphincter complex. And when the head is coming out, up here at 12 o'clock we have bones. We have the symphysis bone up here. So all the force has to go down to the perineum. So this area between the vagina and the anus is called the perineum or the perineal body. So when the head is coming out, it's quite common, especially in women who give birth to the first baby, that these muscle structures, they cannot stretch enough, they break. So usually the women have a tear that goes down here in the perineum, affecting these muscles. And when the tear is going down to affect the bulbocavernosus muscle or the transverse perineal muscle, we call it a second-degree perineal tear. And if the tear goes down affecting this muscle, which is the anal sphincter muscle, we call it a third-degree perineal tear. And these third-degree perineal tears we are very, very interested in protecting. We don't want the tear to affect these anal sphincter muscles. And why is that? Because we know from many different studies and also from registered data that we now have in Sweden that women who have a tear of this anal sphincter muscle have a big risk of anal incontinence during the rest of her life. So even if we identify this tear and suture it properly, we see that many women have problems afterwards. And if you have anal incontinence after a third-degree tear, it's very difficult to cure. We don't have a lot of good treatment options. So it's usually a chronic problem that young women have to live with the rest of their life. Approximately 1/3, so 30% of all women who have an injury of this anal sphincter will have gas incontinence. It means that you cannot hold farts. So when you need to pass the gas, you cannot hold this and the gas is coming out involuntarily. And this is very shameful and disturbing for women, of course. And about 15% cannot hold stool, so they leak stool in their pants. And this is, of course, as you all can understand, a big handicap for the women. So we try to do all we can to prevent sphincter injuries. And we have another video in production where we will demonstrate perineal protection techniques on models. But in this video we will discuss the role of episiotomy. So when we perform an episiotomy, it means that we put local anesthesia in this perineal area, and then we put our scissors and we cut. And why do we cut? To prevent tears in the anal sphincter. You see, if you would take the scissors and do what we call a medial episiotomy and cut down, this doesn't prevent sphincter injuries. Actually, the studies show that it increases the risk of sphincter injuries. But if you take your scissors and you put them minimum 45 degrees, but preferably 60 degrees, you put your scissors here and you cut. You make a cut, you cut these muscles, the bulbocavernosus, and sometimes even the transverse perineal muscles. You will have the tension going away from the sphincter. So the tear, you kind of guide and direct the tear to go away from the sphincter. So you give more space and open up the vaginal orifice, but not going down, it's going laterally away from the sphincter. And this, of course, causes a trauma to the perineal body, and it has been debated wildly if we should perform episiotomies or not. And we have studied this in many countries for many years, and we can conclude that we should not cut routinely. So in women who have normal spontaneous birth without vacuum delivery, we should not perform routinely cutting of the perineum. We have to cut about 65 women to protect one sphincter injury. So routine cutting is not something that we recommend. We could have a situation where the baby is in stress, so that we see that the heartbeats are going down, we see signs of the baby starting to be asphyctic, and this could be an indication for cutting, because when you cut the perineum, you don't have to wait so long for the stretching of the tissue. So it's more fast and easy to get the baby out. So one indication for cutting in spontaneous delivery could be that the baby has to come out more fast. Because when you give birth to the baby the first time, it takes time for the pushing so that these muscles and tissues will stretch and the baby can be delivered. But if you perform a cut, this might make the process faster. So fetal distress might be an indication for episiotomy. But the other part is this protecting of the sphincter. And when we cut, before we start to speak about the EVA study, we will speak about how to cut properly. And so when the baby's head is coming out, all these muscles will be stretched a lot. We put local anesthesia in the area where we think we are planning to perform our cut. We can do it either on the right side or on the left side, it doesn't matter. Usually you have to just develop your own technique. And it's very important to try to calm yourself and not be in stress when you're about to perform the cut, because you really have to give time to look at the correct angle of the scissors. So don't cut when the mother is pushing and there is a lot of things going on. You wait for the contraction to go away and that both you and the mother are calm. Then you put your fingers inside the vagina in the area you see here behind where I'm planning to cut. So I protect the baby's head. You cannot just put the scissors without protection. You have to put your fingers to protect the baby's head. Then you take your scissors, you place them, and then you look. You have to see that you have an angle. If this is the midline, you have to have an angle of minimum 45 degrees. But I recommend that you go even further, because if you put your scissors a little bit too much down, you will cause a sphincter injury. You will cut down into the sphincter. So put your scissors minimum 45 degrees, but usually 60 degrees is better. And then you cut. It doesn't help if you cut only 1 centimeter. that's only causing harm, and this goes down to the sphincter. So you have, if you cut, then you have to cut a few centimeters, minimum 3 to 4 centimeters long. So then you really get a big area of opening, and this will protect the force to not go down into the sphincter. So now we will come to this study, because it has for many years been debated if we should cut or not when we perform a vacuum delivery. This means we do an instrumental delivery. And a vacuum means that the doctor places a little cup on the baby's head, and the vacuum kind of sucks this cup into the fetal head. And when the mother pushes, the doctor can help to pull the baby out. And why do we want to use this? We have actually two main indications. One indication is this, that the baby is in stress. We see low heartbeats, the baby has to come out faster than the mother can push it out. So we have a more stressful situation, we have to get the baby out now. We don't have time to let the tissue stretch. So, for example, when a mother gives birth spontaneously, she might be pushing for 30 minutes or up to an hour. But when we put the vacuum, the baby is delivered maybe in a few minutes. So the tissues doesn't have so much time to stretch. Another situation can be that the delivery is prolonged. So the mother is pushing and pushing and pushing, and the baby is not coming out. So the baby is feeling good, but the mother doesn't have enough strength, or the womb is tired. The womb muscle tries to give contraction to push the baby out, but the muscle is tired. So then the doctor might help with the pushing to pull the baby in the same time. It might be due to that the baby is lying in a position that is not optimal. So maybe the head is little tilted in some way, or the baby is big. So you need extra force to get the baby out. So in these two situations, you can understand that if there is a bigger baby or a baby lying in a not optimal position, there is an increased risk that we will have a sphincter injury. And also if we pull the stretching of the muscles, we don't give that enough time because we are in hurry, and this increases the risk of a big tear. So when we look at data, we see that approximately 12 to 13% of women who need help with vacuum delivery will have a sphincter tear. So more than every 10 women will have this sphincter injury when we do a vacuum. And when we look at observational studies, we see that women who, where the doctor has performed an episiotomy, they seem to have a lesser risk, a smaller risk of sphincter injury. But this hasn't really been confirmed in a big, good randomized trial. So when we look at what we call observational data, we see that the women where the doctor has performed a cut, they have a lower risk. But one can argue that maybe it's another factor. Maybe the babies were smaller, or the person who was performing the delivery was more experienced. So there can be other factors explaining why there was a lower risk of sphincter injury. So this is why we in science, we want what we call randomized trial. So we have a woman, we roll the dice and see if you go to this treatment or this treatment. And then we know that all these other factors are randomly in both the intervention group and the control group. So in this study is called the EVA study, and you will see the reference here. And the EVA study is actually a Swedish study, And in this study, we have about 700 women in 8 hospitals in Sweden. So it's a multi-center study, which makes it even better. We have 700 women who give birth to a baby with vacuum-assisted delivery. And half of them were randomly allocated to lateral episiotomy. And lateral episiotomy means that we cut 1 to 3 centimeters away from the midline. So this is the midline, and we go 1, 2 or 3 centimeters away from the midline, and we cut minimum 45 degrees. So this is lateral episiotomy, and the other group were randomly assigned to no episiotomy. So no lateral episiotomy. And the results in this study showed that the women who were not cut, so no lateral episiotomy, we had 13% who had an anal sphincter injury. And in the group where we performed the lateral episiotomy, we had only 6% that had an anal sphincter injury. So it reduced the risk to half, and this is a big risk reduction. So these results really confirm that an episiotomy during vacuum delivery will protect the mother, not fully, but with a risk reduction from 13 to 6% from having a sphincter injury. And this is big news. A well-designed study published in the British Medical Journal. But there are some aspects that I want to highlight that is also important to mention. So when we look at complications, we know that from before, and this was also confirmed in this study, that the episiotomies are more prone to wound adhesions. This means that there is a bigger risk that the wound breaks down. So the episiotomy, when you stitch it after delivery, that it will break down and open. And the risk in the episiotomy group was 9% that we have a wound breakdown and we have to maybe stitch it again or do something. And the risk in the no episiotomy group was 3% from wound breakdown. And also, when we look at infection in the wound is correlated with wound breakdown. We also had 9% of infections in the episiotomy group and 5% in the spontaneous tear group. So we have a little bit more wound problems and complications when we perform an episiotomy. And now, at least in our hospital, because there was a big Cochrane review guiding us, we give antibiotic prophylaxis when we have vacuum-assisted delivery and an episiotomy. So we try to prevent or reduce this risk of wound infection or wound breakdown. But this is something that it is on the negative side for the episiotomy. Another important question that this amazing EVA study is looking at is that there are myths kind of saying that women with episiotomy will have more long-term problems because they have pain or dyspareunia, that means pain during intercourse, or sexual problems in the long term after her delivery. So EVA study is following up all the women after 1 year, 2 year, 3 year, and up to 5 years after their delivery. And now we just have the results from the 1-year follow-up. And this study shows in all the ways you can look at these women with different kind of questionnaires, and we look at dyspareunia rates, we see no difference at all and no indication of difference between the episiotomy group and no episiotomy group. So the follow-up shows that we don't have any long-term negative effects from episiotomy. So this, I think, gives us doctors something to think about. If you perform a vacuum and you are maybe not so experienced, or there is a hurry to get the baby out, we have now really a lot very good evidence supporting that we should perform an episiotomy. Because if we don't and the woman gets a sphincter injury, you can really question yourself if you are performing or doing evidence-based practice. Yes, so this is something that I wanted to share with you today. I hope you enjoyed it and you have some more insights in this question. And in coming episodes, we will speak about manual perineal protection, which is another super important part in protecting from anal sphincter injuries. And also don't miss to check out our episiotomy suturing video, which is excellent, because when you perform an episiotomy, you have to be very, very skilled in repairing that. And it's much more difficult to repair an episiotomy compared to a spontaneous second-degree tear. So in this video, we demonstrate how to do it with an optimal technique, and we give some tips and tricks that prevents women from having these wound dehiscence problems afterwards. Okay, so see you next week and have a good day. Bye bye.